Now, what we're going to do now is a demonstration of the upper quarter screen and the lower quarter screen that will take us into the shoulder and the back. I'm including in your packet, your handouts, a worksheet that I use while I'm evaluating patients that prevent me from forgetting to do things that I need to do on my evaluation. That worksheet looks like this, and I'm going to be talking off of it, so you will have it in your handout, and you can go by it as we are going through this procedure. The top of it just has the date, the name of the patient, the doctor, the occupation, and then we get into the chief complaint. And you have to be sure you have the age of the patient, because many problems are age related. The first thing on our worksheet is the details of their pain. The first thing you do is you want to establish the onset. Am I too close?
No.
The onset of the pain, was it insidious or was it sudden? Was there a trauma? Trauma, like I said before, always must be accompanied by x-rays, because fractures clinically appear the same, at least avulsion fractures clinically appear the same as tendon problems. So you have to have anytime you have a trauma, you need to have an x-ray to verify that there's not a fracture of the bone. So the details of the present pain, and you can follow along on your handout. The site and boundaries of the pain is the pain. Where's the pain located in the upper quarter? Sometimes it will be in a dermatomal pattern, which will lead you to a radicular type symptoms. Is there headache associated with it? Where is the headache? Is there face pain associated with it? The nature of the pain, whether it's deep, shooting pain. Deep pain many times is referred pain, and we talk a lot about referred pain in general principles, so you know what I'm talking about there with either segmental referral or extra segmental referral. Is their problem constant or intermittent with the pain? Is the pain there all the time, or is it intermittent? Patients will usually tell you it's constant. It hurts me all the time. But that usually is just their interpretation of what is going on. And if you get in more detail, you will find out that if they're at rest and they're not moving it, it is not as painful as it is when they are moving it. Constant pain is a yellow flag, and sometimes turns into a red flag, because musculoskeletal problems are not characterized by constant pain. Is the pain getting worse? Is it getting worse recently, or is it just gradually getting worse? And this will give you an idea of the stage of the problem. And then you want to ask the patient where their worst pain is, because many times they will not be able to localize the pain very well unless you ask them, where is it really? Well, my whole arm is hurting, or my whole neck hurts, or my face hurts, whatever. And you ask them where the worst part of their pain is. Well, the worst part is right here, and it kind of goes up from that and down from that, et cetera, et cetera. So where the worst pain is your first clue about the pain, because you want to evaluate the pain, and that's the pain that the patient is coming in for. Now, does the patient have other symptoms other than pain? Is there weakness? The patient will usually tell you if he has weakness. He can't do certain things because it requires strength to do them. He may not be able to put the upper quarter part into a place without creating instability. Whereas if he turns a certain way, he feels like it's going to come out of joint. So stability and weakness. You want to know if there's swelling. And swelling you don't very often see in upper quarters, and you see it even more rare. It's rarer in the shoulder. The main times that I've seen swelling in the upper quarter are when patients are on anticoagulant medications. And this is, you're talking usually about effusions, then where you have blood leaking into a joint, causing the joint to swell. Of course, you can also have local swelling from contusions and that kind of thing. Do you have paresthesias? And you just explained to the patient what a paresthesia is, and you want to know where that paresthesia is, because that can lead you to a segmental area of specific exam. Does the patient have dizziness, visual symptoms? These are important upper quarter screens because of the vertebral artery, all of the blood problems that you may be associated with a upper quarter problem. You want to know what aggravates their symptoms. And usually this will be a positional thing where if they use the extremity in a certain way, it hurts a lot more. And so that again will lead you to a specific exam. Do you have any objective tests available to you? And many times patients will bring them into you. They'll bring in an MRI, they'll bring in x-rays, and if they do, this will also of course help you. If you let's say the patient brings their cervical spine films in and they have a reversal of curve of the normal lordotic curve of the cervical spine, you automatically know that there is spasm and there is a problem in the neck. So you'll have to examine that in more detail. The onset of previous attacks can also be relevant because many problems are recurrent, especially in the neck, where they come and go, sometimes for a lifetime. Okay, so that is your subjective history, and the subjective history many times will lead you right to where you want to go to examine in detail. So the next thing we're going to do on our upper quarter screen is objective movement testing. With the objective movement testing, we're looking for 3 or 2 of 3 things only. We're looking for the active range, and we're looking for strength, and we're looking for pain. Okay, so you want feedback on those 3 things, or 2 of those 3 things. So the first thing we're going to do is just inspect the patient and look for different contour, etc. changes on inspection. So Julie, you can just come up here now. So we will look at the patient from the front and relax. Now you have to relax, that's it. Put your feet a little bit apart so you're in normal standing. Okay, good. All right, now we'll look at shoulder. I'm in front of you.
First of all, let's do it quick.